Time I'll just start my presentation. The presentation is about the lumbar foraminal stenosis decompression from L1 to L5 level. The decompression for the different levels. Little bit of theoretical discussion. So as we all know that the foramen is bonded superiorly by the pedicle, inferiorly by the inferior pedicle, anteriorly by the vertebral bodies and disc, and posteriorly by the superior articular process, inferior articular process, and ligamentum flavum. So as we go down from the superior lumbar superior levels to the inferior levels, we know that the lumbar foramen decrease in the size both horizontally as well as the vertical diameters. So the foraminal stenosis is most common at the lower lumbar levels like L3, L4, 4, 5, and 5S1. It is very uncommon at upper level. The cause we already know, the upper level they are less mobile, the dynamic forces are very less, and at the lower levels the dynamic forces and degenerative forces they are very high. So the foraminal stenosis, the causes of foraminal stenosis, they are high at lower level. So this is the least classification. We are not going to detail of classification. So this classification depends on the perineural fat obliteration and morphological changes in the nerve root. So what are the basic causes of foraminal stenosis? The foraminal disc, end plate osteophytes, and on the concave side of the degenerative scoliosis because of the narrowing of the foramen. These three causes, the incidence of these causes or incidence of lumbar foraminal stenosis in L1, L2 is most commonly caused by the soft disc or the end plate osteophyte. The other causes, they are more common in the lower lumbar level, like the SAP impingement in collapsed disc, hypertrophic SAP, thickened ligamentum flavum, then the thickened foraminal ligament, and the spondylolisthesis, which causes pseudodisc and the foraminal stenosis. So if you see the first image, in this case, the foraminal stenosis is purely caused by the disc. In the second image, it is caused by the disc as well as the flavum. In the third image, you can see the tip of the SAP, which is impinging on the nerve root and causing the foraminal stenosis. In fourth image, it is the disc and flavum, then the disc, flavum, and SAP. In lower level, as far as the lower lumbar levels are concerned, the foraminal stenosis is always multifactorial. But at the higher lumbar level, like L1, L2, the foraminal stenosis is mostly caused by the disc. So for the upper level like L1, L2, as we know that the lumbar foramen is wider in this case and the degenerative forces are very small, very less, and the cause of the foraminal stenosis is disc. So usually in the upper levels like L1, L2 and L1, L2 and 2, 3, the foraminoplasty is not necessary. So what is foraminoplasty? Foraminoplasty is the widening of the foramen by resecting the SAP. At the upper level it is not necessary, but if you consider the lower levels from 3 to 5, foraminoplasty is always necessary for the foraminal decompression unless the foramen is wider. So there are two ways by which the foraminoplasty can be done. First, with the use of the trephine or reamers under the fluoroscopic guidance, but this is comparatively a blind procedure with the higher complication. And there is a second way, we can do the foraminal SAP resection in a full endoscopic view with the high speed burr, with the high power burst. So next step is anesthesia. So it is again, there is a surgeon preference. A lot of people, they do it in local anesthesia, but you can do it in epidural as well as the general anesthesia. As far as position is concerned, the patient is prone. As far as the lower levels are concerned, obliteration of lumbar lordosis helps. But for the upper level, it is not necessary to obliterate lumbar lordosis because the foramen is already wider at that level and the forces of lordosis are not there. So the skin marking, which has already been discussed in a lot of presentation, we take a midline skin, midline marking. Then this second is the inferior end plate, and third is the disc inclination line. So as far as the foraminoplasty is concerned, our target is not the center of the disc. Our target is the lower part of the foramen. So we usually mark the lower end plate, not the center of the disc. So this is the most important step as far as the transforaminal surgery is concerned. Spend your time, spend your half hour in needle placement, but this is the most crucial step. If you miss this step, you will be in hell. So first of all, if you see at the upper two images, the retroperitoneal organs, they are in very close proximity to our needle trajectory. So in such cases, if you are dealing with the upper foraminal stenosis, I would always recommend to read the MRI or CT scan carefully before surgery and plan your entry point accordingly. So this is the entry point at the L1, L2 level. Approximately the safe distance would be around 5 to 8 centimeter and the angle would be around 45 to 55 degree. If you go below the 45 degree of flat entry, there is higher chances of entering inside the retroperitoneum. Again, you have little bit of liberty at L3, L4 and L5, L5. You can go little bit laterally. This I do in my private practice when I plan any transforaminal surgery. I ask my radiologist to give larger FOV, that is the field of vision. where the entire body comes into the MRI picture, where you can calculate your distances preoperatively, and which significantly reduces the chances and the apprehension during surgery. So next step is the after you mark your needle entry point, next step is to introduce your needle. See, in conventional transforaminal surgery, our entry point or needle target point is the medial pedicular line. But as far as the transforaminal surgery is concerned, you do not want to go inside. In most of the cases where the pure foraminal stenosis is there, you do not want to go inside the disc or inside the epidural space. So the target point is from the mid-pedicular line to lateral pedicular line. The tip of the needle is targeted towards the lower part of the foramen at the SAP transverse process junction or the SAP pedicle junction. Next step is the putting the dilator inside, then the working sleeve, and then the scope. So as soon as you enter inside, the endoscopic picture will be like this. You will be encountered with the soft tissue over the SAP. Try to remove the entire soft tissue over the SAP. You can RF it. See, again, the one important stage is take your time to remove the soft tissue and take your time to identify the structure. As far as the foraminoplasty is concerned, the most important landmark is the SAP pedicle junction. Identify the junction because your work is going to start from the base of the superior articular process. So in many cases of pure foraminal stenosis, you need not to go inside the disc or inside the epidural space. So this is how you can remove the soft tissue or the SAP.
Last 30 seconds.
Yeah. So the next step is the resection of the SAP. So while doing the SAP resection, always remember your starting point should be the base of the SAP. Start drilling the SAP from the base towards the tip, not from the tip towards the base. So this is the video. The tip is being resected from base to tip. So these are the steps which are common in all the foraminoplasty cases. Now the things changes according to the pathology. If it is a disc, you can go inside and remove the disc fragment. If it is a tip of the SAP which is impinging on the root, you can go inside, remove the tip, remove the ligamentum from that side. The rest things will be same. So there should be always the end point of the surgery. In foraminoplasty, the end point will be seeing the axillary flat, visualizing the root from proximal to the lateral exit zone, and the pulsation of the nerve root, which is the indirect sign of the decompression. Thank you very much.
Thank you, Dr. Srikanth. The next talk by Dr.